we'll start with skin because that's the easier and kind of compare and contrast. And I think it really is important to understand that there's been a shift in what we've seen. I mean, if we go back to even 1994, 1995, we really didn't see that much MRSA in the community. And the MRSA we did see was not the traditional, what we describe as a community-acquired MRSA. And we know that those individuals, you could still get the USA strain 100, looking at its resistance pattern and identifying it as such. You could still see it occasionally in the community being transmitted person to person or through contact in people that had not been in the hospital. I think one of the first ones I saw was somebody who was a driver for a local pizza place that had got his finger caught in the car when he slammed the door, got his finger caught in the door, ended up with an infection, had basically community-acquired infection, but had healthcare-associated type of strain 100 MRSA. And that was one of the first ones I had seen. But we know that community-acquired MRSA really started around 1999 out of the South Texas area, Brownsville, and then kind of spread up the Ohio River Valley. By 2004, 2005, most communities were dealing with that. And the difficulty we have today in dealing with skin infection and skin structure infection is that without a wound, everything is empiric. You don't have cultures. And so if you don't have a wound, everything is a guess. And so you kind of have to look at your resistance patterns and look at what's going on in your institution, your community. And we've actually seen a decrease in MRSA in the last 4 or 5 years. We're about 50% for I think 2 years straight now. Before that we were around 55%. So in other words, if somebody came into the hospital and had a culturable Staph aureus infection, about 50 to 55% were MRSA. And now we can even say that out of that 50%, probably 85 of that 50% are community-acquired MRSA. And just a little bit different resistance pattern, the USA strain 300 versus USA strain 100. And they usually look at, community-acquired MRSA, usually a little bit more Clinda resistant. You may have some Levaquin susceptibility. But traditionally, what we see right now with USA strain 100 is a much more resistant strain. And traditional community-acquired MRSA or USA strain 300 is a little bit more sensitive, but yet still is resistant to obviously oxacillin or methicillin or screening agent. And then if you look at unit players, if somebody's in the intensive care unit and has a gram-positive cocci, it's about an 85% chance. If it's in the sputum or from blood or et cetera, it's about 85% chance that that's going to be MRSA. So the old days of starting out with nafcillin or using an aggressive program with acefazolin and seeing if a patient improves after 48 to 72 hours is gone. You just can't do that anymore because the nature of what we see is resistance and what's out there. So you almost always have to cover for the possibilities of MRSA. Now that doesn't mean you have to go to the higher evolutionized therapies or the newer therapies, but ultimately you have to be aware of that risk and make sure you're covering. And in the skin, as I mentioned, the vascularity is so good that MIC creep is not as important. You can treat most community-acquired skin structure infections with vancomycin if it's MRSA. And the issue of the 30% failure rate that we talk about with MRSA, that's more in deep tissue than it is in individuals presenting with skin. The problem is that if you have an individual who has a traditional community-acquired MRSA, in other words, they're presenting with the traditional furuncle or a carbuncle, and for those of you who don't, I remember hearing those phrases from my grandparents, and I thought they were using layman's terms. We were talking about boils and abscesses. No, they were using the medical terms. So a furuncle is a large area that's usually greater than a centimeter that will usually then drain through a single draining foci. They can still develop into an abscess, and so you can develop an abscess from that. But if it's a large area with one draining sinus, that's usually what's referred to as a furuncle. And if you get a larger one that has multiple draining sites, that's what's referred to as a carbuncle. And so ultimately with community-acquired MRSA, we see a lot more of these skin abscesses. And if we compare and contrast, if we talk about healthcare MRSA or healthcare-associated USA strain 100 traditionally, if we talk about that organism, most of those people, if we look at those numbers, it's almost exactly opposite. About 85 to 90% of those people are going to have invasive infections, bloodstream, catheter-related bloodstream, infections and pneumonia, etc., osteomyelitis. So it'll be more invasive. Whereas community-acquired MRSA, it's about 88% of the time you're going to see it as soft tissue, and only about 12% of the time you're going to see it invasive. And where you tend to see it invasive, outside of the bloodstream that is going to be primarily in bone, or usually in children, where you're talking about pneumonia, where you have a little bit higher incidence of the necrotizing pneumonias and the horrible staph pneumonias. And you see that more in younger kids, usually younger than 10, causing just a severe acute infection. So I think it's important to understand that the types of MRSA we see has a little bit difference in presentation, whether it's a healthcare or USA strain 100 versus community acquired, which is going to be USA strain 300. It's going to be more skin structure. And where I was going with this is that if somebody's presenting with the furuncle or the carbuncle or the abscess, they're going to have a slower level of progress if it's not a mature abscess, because until you drain it, it will not resolve. And so if it's caught early enough that you can probably resolve it with antibiotics alone. If not, you want to do things to try to foster its maturity or maturation using heat. Moist, warm packs is a good thing to use on a staph abscess or a furuncle or carbuncle, whereas in contrast with strep, if you don't know if it's staph or strep or it's just cellulitis, don't do it. You would only do this where there's a firm indurated area of a nodular change that classically looks like a staph, furuncle, or carbuncle, or maybe an immature abscess. Putting heat on strep is like putting gasoline on a fire. Toxin gets much worse because you increase vascularity and the body responds to the toxin. That's where you get your blistering and all of those horrible things. Staph, when you get those people that have got that horrific cellulitic area along the anterior patibulary area or along their arm that starts to have a lot of blistering, that's almost always strep. Very rarely does staph do that. So in those circumstances, there could be advantages, and it's all theoretical. Is there an advantage to using something that might block toxin production in those individuals where it's early on or if it's progressing? And it's a debatable issue. Nobody really knows. Is a doxycycline or a tigecycline or a Zyvox better than vancomycin in that circumstance? And I think you have to go based on your own clinical experience and what you've seen in your community. So when we talk about traditional therapy in skin, and we'll start with skin structure and go from there. When you talk about traditional therapy with skin, I think what you tend to see is you tend to get a picture where ultimately most people, if it's a mild to moderate infection, you can try something like a clindamycin or a doxycycline. I prefer minocycline over doxycycline because it's just a little bit better activity against staph. But if they don't have insurance that covers minocycline, then doxycycline, yes.
The minocycline is actually cheaper than Doxy right now.
It's amazing. I just saw something.
There's a single supplier of doxycycline, and so the price for a 500 tablet bottle went from about $57 up to $1,680.
I just had a patient said that
So
for 3 months it was going to cost them $500.
Yeah, so minocycline may actually be the way to go right now until another company steps in with the Doxy.
So I prefer minocycline over Doxy for staph and for skin anyways. And so for mild to moderate, people say, well, what's that? I would tend to think of more of a folliculitis. So if people have got little hair follicles that are red, maybe pussing out with some little pustules, that'd be more of a mild to moderate type of an infection. Maybe it's on their chest, maybe it's, and as you know, a lot of these individuals with infections, they come up with this, it'll be along the gluteal fold region, underwear line, so to speak. Some women along the bra lines, it's in those areas itself. But traditionally it's where clothing meets a hairline. So it can be at the area of right at the hairline on the back of the neck, under the arms. It can be and many times it's going to be in the posterior thigh, just where the buttock meets the thigh itself, right in those regions. And it's really where an underwear line is more than anything else. And just simple abrasion causes mild germ to become invasive, and if it's got enough toxin in the right circumstances, can cause an infection to evolve in those. And so for mild to moderate infections, Clinda and minocycline, doxycycline, certainly Bactrim are mainstays of therapy. Then if you move into a larger area where you're getting a furuncle or a carbuncle or an abscess, then I think that's where you look more to something like a Bactrim. And when I dose Bactrim in skin, and somebody asked me for this journal site a long time ago, and I can't remember where I saw this, and I've not had a chance to look it up, but I was always taught that when you use Bactrim in skin, it's 7 to 10 milligrams per kilogram based on ideal body weight. So if somebody's a 70 kilogram person, that'd be 700 milligrams based on that trimethoprim component. And so there's 160 milligrams of trim in a double strength tablet. So 2 double strengths can be about, you're looking at 360. So obviously in a 70 kilogram person, you're gonna want, to get into the 7 milligram per kilogram, you're gonna have to one about 3 times a day or 2 twice a day. So I always tell people, if they're about 125 pounds or less, use 1 twice a day. About 120 pounds, about 160, you 1 3 times a day. Once you get at 170 or above, 1 TID to 2 twice a day. And if you have somebody who's over 200 pounds, it should probably be 2 twice a day. Now with that being said, they have to have normal renal function. You're not gonna do this to a 90-year-old or an 87-year-old where their renal function is not gonna be normal. And you have to use your noggin and think about how these drugs are metabolized and make sure you adjust it properly. But I think that's how I look at using these agents and using Bactrim in that circumstance. With that being said, Bactrim is probably the most common reason for an emergency room visit for an allergic reaction. It's more common than penicillin. So, and I think in some institutions it accounts for like the 4th most common reason for people visiting their institution. I think that's got to be an interesting use of Bactrim. Where
You probably need to put some in the water to increase our,
yes.
our senses.
I talked about that with lithium, that people tend to do that, put lithium in the water, so I don't know. But at any rate, just joking. So, there are articles about lithium in the water. I think it's in France I was reading about that.
When would you say that that oral is not acceptable, or are you going to get to that?
Well, yeah, I think, well, it's a judgment call, and I think where do you start using other things? And so where do you get to the severe infection? And I think there's several areas that you look at. And this becomes always the question of should they be in the hospital for 24 hours or 23 hours stay, like we have with 3 North. And I think this is becoming an evolution in medicine where you don't admit people to the hospital, but they don't stay in the ER and come back again. You just put them into a 18 to 23 hour stay floor, a short stay floor like our 3 North. And that's actually evolving into an entire art form in medicine where people are actually short-term medicine specialists, where they see people, bring them in, and then make a decision after 12 to 24 hours whether they need to be admitted or not. And of course, that's where you could do your workup for chest pain and make sure that they get their treadmills and get them out. And if somebody clearly is having an MI, then they get admitted and they have the appropriate workup. But what I start to look at is a very large abscess or a very large carbuncle or a huge area surrounding erythema. I remember a case I saw about 1.5 years ago over at Sparrow, and this guy was a painter that had moved from North Carolina to Michigan, and on the way up through Pennsylvania, they just went a little different direction, but on the way up through Pennsylvania, he had developed a small area of swelling and pain along his anterior axillary line about mid-rib cage. And it was described as about a 5 centimeter area of erythema and induration, but it was not clearly an abscess at that time. So they gave him some Bactrim. He then continued on his journey and was showed up in Michigan about 2 days later and got admitted the day afterwards. And I was called for a possible skin abscess with MRSA. And so I went and saw him, and this guy had an abscess that was probably about the size of a grapefruit that had about 7 draining sinuses. It was about 2 inches off the skin in terms of, and then he had an entire chest wall was surrounded with erythema. Well, obviously that's a no-brainer. This guy needed to be in the hospital.
Does a fever by itself indicate that you need to be admitted, or can fever?
I think it depends on what you're looking at. If it doesn't look too horrible, I think you can certainly put somebody on therapy and either have them come back in 12 hours or you can have them follow up with their family doctor the next day. You gotta have some feeling that they're reliable. On the other hand, if I have somebody like we just got consulted on somebody today who's got a wound infection that's probable, you can put the entire tip into the wound, and now they've got cellulitis and induration going down their arm to their elbow, chest wall. You get somebody like that, you have to admit them. And so this person wasn't like that yesterday, but what gives you that inclination that it might be? An advancing area of pain where it doesn't look that intense or that significant? And my guess would be, at least the way I look at these things, is if I see somebody I don't feel comfortable with, I just admit them. So a fever in and of itself, maybe not, but if a fever in a white count, I probably will. Because now you at least met criterion for a serous sepsis definition by having 2 elevations, so elevated white count and an elevated temperature. Again, if they had a temp of 102, 103 and that kind of cellulitis, yes, I probably will admit them. 100.5? No, probably won't.
Is it better to not treat the fever?
Depends what you're going to treat it with. To me, I don't think it makes a huge difference in treating the fever with something like a Tylenol, because it's going to be a short-term relief. And as we look at that, it's not really good. It's it has some characteristics, but it's not a great anti-inflammatory. But the negative side is you don't want to necessarily block that inflammatory response anywhere. So you don't want to necessarily give them an NSAID, which may then decrease your ability to immune response. So it gives you a double-edged problem. Not only are you decreasing inflammation and the temperature, but you also decrease your ability to fight infection. And so if that takes off, that's one of the things that are highly associated with the quote, flesh-eating bacteria when you look at group A strep. Not so much with MRSA, but there's a constant debate about which toxin is really responsible for causing the abscesses in community-acquired MRSA. And those of you who've heard me talk about this before, I tend to think it's the pantine valentine leukocidin, or PVL. Dr. Havlicek isn't quite sure. He still thinks it might be toxin A, so he's not sure which toxin it is. I don't think there's any question that PVL is what's responsible for the necrotizing pneumonia. There's been really solid studies done that have looked at this, and if you're not familiar with this, it's actually a different genetic mutation that you get in community-acquired MRSA. It has nothing to do, like for instance, if we talk about the MEC1 type class resistance that you get with healthcare-associated MRSA, it's either a MEC1 or MEC2 type of mutation that occurs, where it's usually a MEC4 or MEC5 with community-acquired MRSA. And that has a lot to do with the differences in its characteristics being invasive versus being skin-related. But the PVL is not related to the MEC mechanism of resistance. It's a completely different gene. But for some reason, these community-acquired MRSAs, about 99% of them carry this PVL. At least 95% of them do. And my experience has been nearly 100%. And I think it's the PVL that does a lot more of this and causes problems. So getting back to your question, I think it depends on what you call fever. I mean, if I have somebody 101.4 or greater, I'll probably admit them, at least as an 18 to 23 hour stay, because I'd like to see this turn around before I send them out. If somebody says my temperature is 96, 99.6 is a fever for me, I'm not so impressed with that. That may not be normal for that person, but we know we treat in terms of what definitions of how severe something is. We tend to treat based on what we see and what's defined. So a lower grade temperature, I'm not going to bite on that just by itself. But if the white count's elevated, they have a fever, certainly I'd admit them, and if it's progressive, I'd admit them. So that's the biggest issues. And so that's kind of how I look at it from a community perspective. You know, nafcillin is nice, but nafcillin will not work for community-acquired MRSA. And if you've got over 50% of the staff we see, I think you can't just buy into the thought that you're going to miss it half the time. That's a horrible percentage with a disease that can be quite significant. So most people tolerate it. They don't necessarily die from this, but yet if you look at the progressive stages, how much more difficult it is to clear them, the length of stay, and then the potential need for other things, wound care, etc. If you can catch it early and be aggressive, it makes a lot more sense.
At what MIC for Vanco would you recommend an alternative agent? Are you okay with a skin infection with 2?
Yeah.
But if it's deep,
I would agree. I think
complicated,
skin,
you have to go.
no, I think
I
don't think you necessarily worry about it. That's probably even debatable at 4, but I don't feel comfortable with a Visa using vancomycin even in the skin. Particularly, I know that we are shooting for levels between 12 and 17, with 15 being kind of ideal, and that's going to be much higher than 4. I appreciate that. I just don't have the same gestalt feeling and experience-wise that works. And it gets back to, you know, what do you see people failing with? How severe is their failure, and what do you do? And I'm not a big clindamycin user. I just don't have a lot of great experience with clindamycin, even in skin. So for me, I personally don't use Clinda at all. But I know the ER still uses a little bit. Certainly IDSA recommends it, but you know, even there's, we're 23% resistant, I think, here for Clinda. So it's a little over 20%. I guess it's 23%, I think.
But you would still add it in somebody who has toxin, for not just for the toxin alone.
I might. It depends on what you're using. If you're going to use Vanco, then I would use Clinda too. The problem with that is you've got to use Clinda first. And that's another important thing to teach residents and people in the ER. If you're going to use it to block toxin production, you should really use that as your first antibiotic administered. Because once you've given, like for instance, we know that carbapenems tend to cause a release, not necessarily in staph, but in gram-negatives. When you talk about that lipid amoiety that induces septic shock, We know that in gram-negatives, certain antibiotics tend to expose more of that than others by how they damage the cell wall. And carbapenems are one of those drugs that you do. So if somebody's in septic shock, carbapenems, gram-negative septic shock anyways, carbapenems may not be your better agent. You may be better off using a penicillin there than a carbapenem.
Because you're going to dump all that toxin out in an
Right.
unprotected environment, I guess.
Theoretically anyways, you could happen. So if you're going to use something like Clinda, I think you want to use it first before you start to induce. My example I give patients or tell students and residents is that it's kind of like swatting the beehive, all right? If I'm a beekeeper, I know I can use smoke to make the bees more docile and easier to deal with. But if I whack the beehive and they're all angry and buzzing, now I smoke, it doesn't have the same effect as if you're smoking before you whack the beehive, all right? So if you think the bees is the toxin and the smoke is being your Clinda, or whether, and Clinda's not the only thing that can do that. We know that tigecycline can do it to some degree, the other tetracyclines do it. Zyvox has been shown to do it. It's a lot more theoretical than proven. I wouldn't deny that. So I think
Clinda's
that's
pretty
true.
innocuous as
Yeah.
far as some, I mean, unless you worry about C. diff.
Unless the organism is resistant.
Right, but I mean, if you add it to something else.
Well, I agree, and that might be for instance, we had somebody that had a horrible looking problem, so we actually, they were neck fash, nobody had given them Vanco or Clinda, so we decided to give them Zyvox as a primary agent. And they already received antibiotic beforehand. So we just added to it by adding Zyvox. And we even talked about this is probably gonna be strep, and it was. And then once we are sure that there's no staph growing and that things are stable, we just pull it back. And it should have the same effect as Clinda. A lot more expensive, absolutely true. In group A strep, most of them should be Clinda sensitive, but if you had staph that you're worried about, that maybe not so much so. So I'm not saying you have to, but I think it depends on what else you use. If you're not going to go that direction of using a tigecycline or a Zyvox, which is going to be a specialized patient by and large, it's going to be the severity of the presentation, then I think you're okay to use Clinda. And then my standard for most neck fash is going to be vancomycin in combination with meropenem, but using Clinda first. And if somebody's already went through 12, 18, 24 hours, nobody added a staph drug, you kind of lost your advantage of Clinda. They went to surgery, you debrided them. That's what we had seen. Nobody had added, so I just basically went the other direction and just added Zyvox at that time. It's kind of the horses out of the barn, so to speak, but at least let's try to keep the damage at a minimum. So that's kind of how I look at it. I'm not sure that answers the question. My experience has been that if somebody, and this is, as you may be aware, I've actually been the person who spoke to Medicaid for the last 2 years in regards to keeping Zyvox on formulary, is that I think if you've got a patient who has been seen and started on an antibiotic and comes to the emergency room, if you can give them an IV dose of a medication and put them on oral Zyvox, it keeps them from being admitted. And if you have somebody who's serious in the office, and again, I'm not talking about mild, I'm not talking mild and moderate, I'm talking about severe infection, I may use it there trying to prevent them from getting in the hospital. Now, from your budget perspective, it's horrible, because if they're already in the hospital, you still have a budget that you have to try to control, and we've got all these issues, and that's the real issue when you're talking to other doctors and trying to steer and guide. How do you give direction to that program? And I think in skin, and Deanne's really been a good proponent of this, is that in skin you don't have to be, and so is Kelly and the rest of you too, but I know Deanne's been a person I've heard talk to other docs about it the most, is that in skin you probably can do a lot more with vancomycin. You don't have to worry about the MIC creep as much because you have so much vascularity, so that the delivery of antibiotic is good. And when we talk to people about synergy, why do we add drugs like gentamicin or something to synergize? And people say, well, it increases killing potential, which is true, but what you're really doing is you're decreasing the amount of drug that's required to kill. So if you've got areas that doesn't have a very good blood supply, now you just need a little bit. Instead of this much, you need this much. And that's really the advantage, I think, in synergy. And some of the other antibiotics where you have an MIC issue, then I think it makes sense. So in skin, I think it depends on the appearance, where they're at. If I've got somebody, I've seen this before, where somebody comes in, they're from the prison, they're maybe in the prison unit now, maybe they're from the jail before, they have 8 abscesses, they've been on Vanco for 48 hours and they're not getting better. Some of that may be because the abscesses weren't mature, but I've seen agents that work at toxin production be more aggressive. I've put them on Zyvox, and then some individuals went to even using Dapto and have a much better in terms of time to kill, an improvement, much more rapid response. And I think it's on a case-by-case basis. You can't say that in this skin with these abscesses, that's what you do. It's on a case-by-case decision. And in those circumstances, then length of stay is where you save money. It doesn't help your budget at all. And so unfortunately, hospitals haven't figured it out, that the bean counters haven't figured out that, okay, maybe we have to have a bigger budget here to save over here. And I think people are becoming a little bit more enlightened to that, but yet we still have that same issue of let's treat the patient properly, but let's not use what we don't need to use and break the piggy bank on something where we can use the money elsewhere that helps us treat other patients who need it.
Is it rational to, let's say, consider if something has happened to that carbuncle or abscess, that then you would have to reevaluate? If you had a patient on Vanco, they weren't getting better, you switched them to Zymox, their abscess was drained, can you try Vanco again, or do you just stay with your Zymox?
I think you probably stay with the therapy that works, but the other advantage there is maybe you can switch them to oral and get them out, depending on their insurance. As we know, the prison doesn't necessarily go along with that.
They don't get to go out.
So you're going to go home on Doxy or Nalmina probably, which in the right setting, once you've dealt with the problem, that may not be an unreasonable thing to ask. One of the things I will talk about is that in those individuals, I've actually seen a 23-year-old who was started on Bactrim DS2 twice a day, he was about 190 pounds, that came in after being on Bactrim having received a day and a half therapy, and his creatinine was already at 1.8. So it's one of those things you do have to watch. You will get some renal, and some people say that's not necessarily renal dysfunction. It's more of how the Bactrim is interacting at the level of the kidney. I'm not sure I'd buy that. I still think that's got to be effect on kidney and nephron function itself. But you do have to watch. I mean, you will see people that are young who have no underlying renal insufficiency who develop some acute kidney injury on Bactrim. So it's cheap, it works well, but you also have to wait. You have to watch your side effects and manage that as well. So, it's part of why I've never put together an algorithm on how you treat skin infection. And I don't know, you may be aware that Sparrow's ER did. Did you hear about it? It's 9.5 pages long.
Oh my gosh.
So they actually post it, like in this area, it goes almost halfway around the room.
Like a border.
So how many people do you think really come in and look at that?
Wow.
And they were so proud that they had done this, and Dr. Tran worked with them to put it together, and I'm thinking, and I just think back to when, IDSA and ATS combined their community-acquired pneumonia guidelines and came up with a 56-page document. And somebody asked, I was there when they asked Andrew Shore, who's a critical care specialist, somebody said, Dr. Shore, how do you get a 55-page document or 56-page document out of something we've treated for the last 25 years successfully? And he answered with a simple question. He says, you know what a racehorse is? Oh, yeah. He says, no. Do you know what a racehorse is? He's a racehorse. He says these protocols are racehorses designed by committee. And what happens is you start tacking on all these things. Instead of getting a racehorse, you get an elephant. Because everybody starts putting you got to take care of this problem, you got to make sure this is included. Because if you're a professional society that puts together a guideline, you're not legally liable if somebody uses that guideline and they failed for something that falls outside the guideline. So you have to put all that stuff in there. You have to discuss and describe it somewhere. And then you have to have your level of, in terms of information and research, whether this is an opinion versus is it well-founded on research and double-blind studies and all those things. So, it's one of those things that it just gets added on and on and on. So the answer is I've never ventured out because it's so hard to do. What about this person? I think the key points to recognize is that if somebody does not have an open wound and is not a diabetic, your chances of having Pseudomonas is almost zero. And so if we look at nationally, the most commonly used antibiotic out of the emergency room for a simple cellulitis is vancomycin and Zosyn. So as you may be aware, we are very aggressive in our Zosyn dosing because we had resistance issues, we still do, but they've improved by using it more intelligently and being aggressive with it. But the part of the fact, if we look at antibiotic stewardship, it says use aggressive antibiotic therapy, then de-escalate quickly. Well, in a disease state where you don't have cultures, You have to rely on literature, and literature shows that only 8% of the people actually have pseudomonas, and if you actually read the actual studies, those people had wounds. You know, you don't just get de novo pseudomonas cylitis without wounds traditionally. So if you don't have those wounds, don't use that drug. And so it starts to guide and direct what we do and just making sense. But the problem is how do you incorporate all those things? Well, what if they had a skin biopsy? What if they have an open lesion? What if they have a closed lesion? What if they had a vascular bypass procedure and they have lymphedema? I mean, you got to include all of those things in a recommendation. And I would suggest that somebody just has a simple, funny looking mole who gets a elliptical incision and a closure is different than somebody with lymphedema who's got a vascular bypass procedure. Those two people are not even the same scenario, but they're both post-operative wound infections. Well, they're a lot different. And so you have to look at every patient differently. So the common, simple person doesn't necessarily have to be aggressive with that. The flip side of that becomes if they improve, I think docs over the last 15 years have gotten used to having an oral equivalent to their IV therapy. You got Zinosef, then you had Ceftin, you got Levaquin, Cipro, both giving you IV oral equivalents. Well, there is no Vanco oral equivalent. There's oral Vanco, but it's not absorbed. So, people don't like that, and I think they're struggle with that. What do we do with this now? What do we give them? And I think it comes down to every patient is different. So there is no great answer, and that's why there's people that are experts that look at horrible cases and say, okay, we need to change or do this. And I think that's also why, as a patient has more of a larger lesion that's more aggressive or more painful, and then you tend to work up into the higher range and the severity, and you might use something like a Zyvox, which is equivalent to Vanco. It's not really better. It's equivalent. So, if somebody's got horrible disease and you don't want to put them in the hospital, it gives you an oral option. But if somebody you want to watch and you're going to put in, you can start them on vancomycin and in 24 hours flip them over to something else. It could even be Zyvox. But you're going to have to flip them over to something else.
If you give them Zyvox, you're going to have to flip them over to home.
Yeah.
It doesn't come out of our tier.
Try to make sure it's covered too.
Yeah.
So.
And it
Well,
takes
yeah,
a little
before you
while.
even write for that, talk about Teflaro for skin structure. Because I don't know what our new ER doctors are going to be like, but we sure use a lot of single dose Teflaro.
Well, let's talk about, I talked about using oral therapy, and let's move on to IV therapy and skin structure. And there's a lot of philosophies on this. And, if I go, and it's no secret, I speak for Forrest on Ceftaroline or Teflaro. But the bottom line is that if you're in an institution that doesn't use it as a primary therapy and they use vancomycin, the only way you can make it cost effective, and Lou Cerebolus does this down at St. John's, is that you do not get levels unless they've been on Vanco for more than 3 days. If you're going to get levels after your third dose, then your savings is probably going to be, and I recognize it's still cheaper to use vancomycin than Ceftaroline, even with a level, but if you keep adjusting and getting more levels, it isn't. And if you look at length of stay for cellulitis versus numbers of opportunities to do that, and this isn't my thought, it's Lou's thought, Dr. Cerebolus. And
Ours used to be 5 days and then we pulled it back.
so if you don't check a level in the first 3 days, then Vanco's probably your best choice. And the question becomes, how often do you really see a gram negative causing a skin infection if there's no wound? And the answer is nobody knows, because it's not culturable, and you can do use a cc or 2 of sterile water or sterile saline, but you gotta make sure it's not bacterial static. You go to the advancing border, you inject it into the skin, bring it back, and try to culture it. I've not had much success doing that. Dr. Kowalczyk has had some success doing it, but I've not.
Does he get staph epi?
Yeah, I've abandoned that. I don't see enough efficacy that works. But I personally like Ceftaroline as initial therapy in that circumstance only because it covers the basis if you pick your patients wisely. But here's the other factor, is that there is no oral equivalent for that either. And so if you use Ceftaroline, you're likely going to switch them to oral minocycline when you're going to discharge, or if they're improving after 2-3 days, you're going to put a midline in them and continue a 10-day empiric course, is what you're going to probably do there. And if people don't want to do a midline, then they're probably going to be switching to something else. amounts.
What's the value of it for a single dose and then discharge or sending them home from the ER? Is there really any value other than it makes them better for the time after
Yeah,
they got
that's a
that
good
dose?
point. No.
I mean, so they got
Whether you
better
use
for 12
Vanco or
hours?
use something else probably makes no difference, I would agree.
Either way, those one-time IVs.
Yeah, I think that makes sense. Yeah, I think the difficulty is recognizing the patient population. When I talk about ceftaroline, and we can always talk about invasive disease another time if you want, because I don't want to take too much of your time, but if you talk about this, the real issue is, remember, ceftaroline, three things about ceftaroline that gives it its advantage over certain things. Obviously, the first cephalosporin that has activity against MRSA, and that carries over into coag-negative staph and some other areas too. Even though it's not enough studies to give it indication, it still has good activity. But it's the first cephalosporin that has activity against MRSA. So it gives you yet another thing that you can use, which can offload your pressure of resistance if some of the things are showing creep and resistance issues. The second thing about ceftaroline is it's not very highly protein bound, so you get a lot of drug, which is what I like about the drug. So if you look at cytality and definition, it's only about 18%, it's about 20% protein bound, we'll say. So that means if you give 1,200 milligrams, you're going to get 960 active drugs, so 960 milligrams of active drug. Whereas if you look at other community-acquired, now they don't have the same definition for where you would use them, but if you look at, if you're going to use something other than vancomycin, it's going to either be probably unison, ertapenem, or going to be vancomycin. You might throw rosuffen in there too, but if you talk about other than vancomycin, you've got rosuffen, ertapenem, ceftaroline, maybe unison. I don't think too many people are going to use unison that have trained over the recent past because its E. coli coverage is not great, and it doesn't give you MRSA activity. Well, neither does ertapenem or rosuffen. So there's a big step difference on these, but even if you talk about strep and talk about staph that's MSSA, remember, if you give 1,000 milligrams of ertapenem, 95% protein bound, you're only getting 50 milligrams of active drug. Rosuffen, if you give 2 grams of rosuffen, you're going to get probably 200 milligrams of active drug, whereas this you get 960 milligrams of active drug. Time above the MIC for strep is virtually 100% of the time. That's pneumococcus. Group A, Group B strep is almost there. So it has really, really good pharmacokinetics. And if you look at drug availability,